Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended the clinic with an outer ear infection, and all this that I'm suctioning at the moment, this is all discharge and debris. It's what we call otter ear. So otter ear is the medical term for ear discharge and pus. And this debris and discharge was fully occluding, so it was extending right from the entrance to their eardrum. And these are the more complex procedures for several reasons. First of all, the consistency. It's like mashed potato. If you've been watching my channel, you know I do enjoy making food analogies and comparisons with earwax with the consistency. And because of this consistency, it's very hard to vacuum. And second of all, because of the viscosity of this, you never quite know how thick the layer is. So as you can see, we're tunneling through, but I don't know at the moment where the patient's eardrum is, because I don't know the viscosity and how thick this layer of discharge. Now I can just see some of the eardrum, and that's now giving me a benchmark. On the left-hand side, you can see a bit of a blue tinge appearing through this discharge. So now I am feeling a bit more comfortable because I've got the depth. I know how far I need to go in. I don't want to over-insert the suction probe, whereas previously I just wasn't sure where that eardrum was. Now we can make an educated guess. Being an audiologist, we're very experienced working in the ear. You have a gut feeling, but we never want to make guesses when we're in someone's ear, well, at least I don't, and it's always best to be precise about these things. But nonetheless, we can gauge due to the shape of the ear and the shadows in the ear that approximately how deep we are in and where one can safely assume the eardrum is. But now that I can see the eardrum, what I'm trying to do is seeing whether this debris can peel away from the canal wall. Sometimes it can. So I'm just working at the base of the ear canal here, and you can see some of the ear canal itself now being visible as I'm trying to remove this discharge. But you can just see it's not suctioning very well, and I've put some drops in there to help. Now, even at this stage, the patient can hear significantly better because the blockage has been removed and the sound can get through to the eardrum. But I want to now remove as much debris as I safely can, and that does mean I'm not going to remove every little aspect because it's just not possible, but I'm going to try and get as much out as I safely can without causing any injury or trauma to the patient. And I don't know whether you've just seen that, but I have already caused a bit of very mild trauma to the patient's ear canal. Just to the right, you can see the ear canal grazed it slightly. Now, that's what we call, that part of the ear canal is the anterior canal wall. And the ear canal in this region, it narrows inwards and it widens back out again. And that narrowing is called an isthmus. And because of the narrowing and widening, it creates a little alcove to the right-hand side. And in an attempt to remove the debris off the eardrum in that region, with the full sucker, I actually grazed the side of the ear canal. You can just see that. So what I've had to do now, I've had to revert to a fine end. And you may have just seen there with the fine end, I've made a little bend, a little kink on the fine end, so I can curl around the front part of the ear canal so I don't make contact with it. Because fortunately, the patient didn't feel it at all, but if I made more of an impact, I could have bruised that part of the ear canal. It would have been a bit uncomfortable for the patient. So we can probably see, I would say, three-fifths of the eardrum already. And again, I'm just using the fine end, and we're actually on the eardrum. You'll probably see the eardrum flex a few times because I am putting a bit of pressure against it in order to suction this gunk out. And that's the best way to describe it. It is like gunk. It's so viscous and thick and glutinous. And once more, you can see that curl, that bend in the fine end. So that's very useful in this kind of case because it mitigates the risk of me again grazing that front part of the ear canal. It's a trick that I learned off a colleague of mine who's an ENT surgeon, Mr Darius Rajali. If you do Google him, if you search him on YouTube, he has got his own YouTube channel now. He doesn't post as regularly as I do, and when he does post, the more surgical procedures, although he has got a few earwax removal procedures on there. But it's a very interesting channel, so do feel free to pay his channel a visit. So again, the majority of the eardrum is clear. Now I'm just focusing at the moment more on the canal walls. And because of the infection, the ear canal's become a bit, there's a bit of edema, a bit of swelling there. It's become a bit spongy. That can work to our advantage because when you've got a bit of edema, swelling, it gives it a little bit of a buffer. So the inner 2/3 of the ear canal, it's a very sensitive part of the ear canal. It's a thin layer of skin, less than 0.1 millimeters in thickness, that lines directly on the bone, the temporal bone. And if you make contact with that, it can be very sensitive for the patient, as I kind of alluded to earlier with the anterior canal wall. When you've got a bit of swelling in the ear canal, it just provides a bit of buffer, a bit of a cushion. So we can sometimes use that to our advantage, but not always. But in this instance, we're able, especially on the outer third, mind you, probably on the inner 2/3, there's less swelling. Again, I'm just making these little brushstroke movements. We're just flicking away, trying to not make contact with the canal wall. Now, this patient's infection was caused by them getting water in their ear. They were on holiday recently, and we've been inundated with ear infections. It's normally the case at the end of the UK summer, because obviously a lot of people go away on holiday and they go swimming either in the ocean or swimming pools, and the water can get into the ear and it can get infected. So we've been really busy just clearing out infections. The best preventative measure is, of course, we want you to go in the swimming pool and the ocean and to enjoy yourself. But if you can wear some sort of swim plugs or swim defenders just to help prevent the water from getting in, that would be great. Now, the incidence rate, I wouldn't say everyone that goes in the water is going to develop an ear infection. Most of us will be fine, but it's hard to predict those individuals that will, unless you've got a previous history. So in other words, you can have 100 people that go swimming in a pool, and the majority, probably 95, I'm just being arbitrary numbers, but 95% will probably be fine. But this 5% will develop an ear infection, and there's no way of predicting which 5% of those people will develop an ear infection unless they've obviously had a history of an ear infection previously. And then once you have one of these infections, it can be nasty, it can be difficult to treat, and it can be several sessions of cleaning and several courses of antibiotics. Patients often ask me when I go for a shower, what do I do? Do I wear any ear protection? I don't. I've got quite short hair, so I'm quite fortunate in the sense where when I'm washing my hair, which very little of it's left remaining, that it's not really going to enter my ear. So, but what I always advise back is don't purposely get water in your ear. So I know I was guilty as a child when I was younger. I used to submerge my head under the water, or before I became an audiologist, used the shower head and flush out my ears, and all those are kind of bad practices. And for those patients that even despite when they're being very careful, they do accidentally get water in their ears, we just recommend some sort of ear protection. You can get things over the counter like foam inserts or silicone inserts, swim putty, even a bit of cotton wool with a bit of Vaseline around the edge. It can create a bit of a watertight seal at the entrance. So I've just put some more drops in. I just want to see if I can just get a bit more debris away. We have written to the patient's GP, because they will need some prescribed medication for this. Again, I've just got to keep mindful of the anterior canal wall there. I think I'm at the moment using the big sucker. I've just reverted back, so just to get more of a surface area, and I got a feeling I'm going to revert back to the fine end again in a moment. So I'm just going superiorly now. You might see that white just to the right of the sucker. Now, that's actually the patient's short process of the malleus. So the malleus is the medical term given to the hammer bone. And the hammer bone has different features. You have the bit in the centre that attaches itself to the eardrum, almost like the bullseye of the eardrum. We call that the umbo. Then you've got the main handle, which is the bit that you can see going upwards from the middle, and we call that the manubrum. And then at the top, we've got the short process, and it's a part of the hammer bone that protrudes outwards. This patient's is protruding out a bit more than the norm. but it's fine. I think I'm more or less complete. I mean, you can see we're right up against the eardrum, and I've just got to be careful because I run the risk of actually going through the eardrum in an attempt to remove debris that may not even be able to remove, but patient can hear significantly better. I hope you enjoyed that video, guys. Take care, keep well, and remember, be nice and be kind to each other. Thank you.